Well, hello, everybody. My name is Garrett Schmidt. I'm the managing editor for VBC Exhibit Hall, and I'd like to welcome you all to today's live webinar hosted by MRO Health. And it is called Overcoming Provider Data Challenges Strategies for Payers. And looking forward to today's presentation. I think you guys will really enjoy it. A few items of note before we get started here, just some housekeeping things. All attendees have joined in listen only mode. So you don't need to worry about muting yourself or turning off your camera or anything. We can't see you or hear you. However, we do want to hear from you. We're going to have a time for some Q&A towards the end of the presentation, as well as some polling questions for you to play along at home, which we'll walk you through. But looking forward to hearing from you. So if you do have a question, just use your control module as an attendee, and you can drop your question there. And we'll get to as many as we can today. If for some reason we don't get to yours or are not able to get it, someone will reach out to you via email to make sure we answer your questions. So don't worry. And then when we conclude, about an hour or so afterwards, you're going to receive an email, and there will be a link to the recording as well as to where you can download the slides from today's presentation. So without further ado, I wanted to briefly introduce our speaker today, Mr. Brad Hawkins, and he is the National Director of Health Plan Sales with MRO. So welcome, Brad.
Garrett, thank you so much. Certainly appreciate the opportunity. Good afternoon to everybody who has had an opportunity to join. We certainly are excited to share insight from MRO and kind of our perspective in the quality journey in value-based care, specifically to health plans. I won't go into all the background around myself, but I did want to, kind of echo Garrett's thoughts, right? That this is meant to be your time and you're spending it with us, and we want to make the best use of that. So if there's any questions that you have as we go through the presentation and some of the data points that we share, feel free to ask away. I'll also say thoughts and prayers with all those Floridians and those in the Carolinas that have been impacted by recent storms. Being a native Texan, but living here in Lafayette, Louisiana, we certainly understand the challenges and the devastation and destruction of those storms. So Godspeed to all your loved ones and relatives and recovery around that. Last but not least, I want to thank you for spending 10-10-24 with me, because today is the World Mental Health Day. And so as we kind of think about what in healthcare would improve our own mental health, I think quality data and improving data exchange between healthcare providers, ACOs, and health plans is certainly at the top of mind. And so I'm just going to give a quick brief overview of who we are at MRO, and then we'll dive into what you came to hear about today. Like, what are the challenges faced with on a daily basis, and what are some strategies to overcome that, and what would that look like in a real world setting? So without further ado, Garrett, am I good to go ahead and get started?
Yes, sir.
All right, great. So for the majority of the folks that have joined today, you probably know MRO as an organization that's, got its start 22 years ago in sort of what's deemed the copy service business, right? Release of information, working with providers in order to handle the chart request or chase lists that are coming into your organization, into these provider organizations on a daily basis, be it for risk adjustment or legal request, et cetera. But I think I would challenge you as you think about who we are as a company, to think a little bit more broadly, because we've certainly changed over the past 22 years. We work with 1,100 hospitals, 35,000 practices, integration to over 250 different clinical systems, and we work with 200 health plans today. And what that gives us is a very unique perspective on not only the marketplace, but a lot of the trends and what has changed. And so we've got 3,000 employees. We wake up every day thinking about how do we accelerate clinical data exchange at a high quality. And so we're working with providers and plans on any number of use cases around value-based care, risk adjustment, HEDIS, et cetera, claims appeal. But ultimately, how do we reduce abrasion and promote collaboration, right? And so, establishing that trust between our partners has been really key to our success. And we're excited about, kind of sharing our insights into this world around value-based care and data challenges that we see on a daily basis. have a few cue cards with me today. So I'll be reading off of those to make sure I've got all of the data points that my team has kind of prepared me for. But I want to make sure that we hit on a lot of those components. Before we dive, really kind of into the nitty gritty, let me kind of paint a picture, right? My dad told me an old adage of, you don't tear down fences until you know why they've been built. So before we start to criticize the market or the system or how did we arrive here, let's think a little bit of like what's happening in healthcare that's demanding that it's not just data exchange, but that it's accurate and there's a high quality need that's being necessitated in the marketplace. It's kind of changing our behavior, right? So we hear it all the time, right? You go to the HIMSS floor, any number of vendors are focused in the world of how do we help reduce administrative costs. Long story short, we've got a lot of it here in the US, more than you see in any other nation. You've got trends like NCQA's pushing for all digital measures for HEDIS by 2030, right? Where are we today versus where we're going? And so these are things that are happening in our market that aren't going away, right? And so we can't avoid the storm or we can't avoid what's happening in the pending future. I think what's also interesting, right, is we've got 10,000 Americans turning 65 every day until 2030 or 2029, right? So that means that, all of those members, we're going to be growing that Medicare Advantage population. And that's going to be a need to really share more and more data and get more and more insight for you as a health plan. I know CMS is really, focused on getting all of those value-based care models applied to that Medicare Advantage population, right? That they're actually part of an organization, they're part of a value-based care plan where they're working collaboratively between the provider and the payer. So all this sounds great, right? So this is, super exciting. We're trying to progress to how do we measure ourselves better? How do we collaborate better? But the challenge is we don't have any staff to do it, right? On the provider end, 75% of clinics are challenged around, how do I share data back and forth between these organizations? I will say just MRO as an organization, working with those 1,100 hospitals, 35,000 practices, we've seen nearly a 400% increase in just the sheer volume of requests from health plan to healthcare provider over the last 5 years, right? So more and more requests on the demand side, less and less people to do it. And so we got to figure out how do we start to adopt interoperability a little bit, but more how do we ensure that we're getting quality data? And so we'll be diving into some specific strategies that we've seen and what has failed in the market as we kind of walk through the rest of the presentation. But this is really kind of painting this picture that like the cat's out of the bag, right? We've got a lot of things that are changing in healthcare on a daily basis, and we've got to start thinking about how do we do this differently. So before we dive in, I'll let Garrett kind of share with you the poll question.
That's right. We've got our first polling question, which should be on your screen now. And this is, where are you on your value-based care journey? We're going to have a few of these. They are anonymous, by the way, so you can feel free to answer. And we're going to show you the results when they come in. That way you can see how you stack among your colleagues. So we've got our answers still coming in, so we'll give it a few more seconds for this. And yeah, are you at a crawl, a walk, or are you on a run? You have it down. So looks like again the answers are still coming in. So we'll give it a few more seconds. Brad, are you able to see on your end?
I can't see it on my end, Garrett. No,
Yeah, all right.
sorry.
Well, I will read out the results here shortly. Okay, I think most of the results have come in. So I'm going to close it down in 5, 4, 3, 2, and 1. Oh, there's always one that comes in right at the last second there. There we go. All right, so here's our results. We have for crawling, we've got 19% feel like they are crawling on their value-based care journey. We've got 52% of you who are walking, and 30% are in a full-out run.
Great. Got a good mix across the board. So yeah, I think that's probably what I would estimate that I think folks have taken sort of their initial steps. They're walking towards this value-based care journey. I think some of the data that we'll share here will probably resonate and be interested to get some additional insight from you around the challenges that you faced. So Look, we could spend a lot of time, right, talking about all of the challenges that impact value-based care success, and we'll talk mainly about, really the drive for accurate and consistent data. But if I had to summarize, I would tell you it's really tied to these three areas, right? So regardless of all of the amalgamation and aggregation, right, consolidation on the provider end, there's still a lot of data silos, right? There's still a primary EHR inside the inpatient setting versus outpatient versus specialty. Legacy data is stored somewhere else off site. And so to get a complete picture of Brad Hawkins from potentially one health system, I'm having to access multiple data sources, right? And so ultimately, all of that's a little bit different. As we talked about, so that's sort of like key element, right? We know that data is disparate across the board. Limitations in resources. Providers are lacking resources to hit the growing number of requests tied to risk adjustment audits, HEDIS, et cetera. They also don't have, let's call it change management or a quality assurance process to ensure that the charts they're sending you or the data that they're sending you as a payer have gone through any type of validation process, right? They have just enough time to just pull the chart and send it along. They're not, checking to ensure that all of the data elements are there that you were looking for, right? And so they already have a full-time job, and so that becomes a big challenge around, well, I don't have the resources to pull the right data, to check to see if I had enough data or had the right data elements. And what that's going to lead to, right? Also, because I don't have the limitation of resources, is a delay in the timeliness of that data submission, right? Where, if you were to go talk to a provider or for the ACOs who are present, you're challenged with this, where everybody's pulling out their hair and they're pulling all-nighters and weekends to make sure that they hit this, large request or, large kind of workload that they're trying to do to share this data with a health plan that they're in a value-based care agreement with. And so those are just challenges that we're faced with, right? Lots of data in different silos, not a lot of people to go pull it. Even more so, and I'd say this is probably where you see the biggest challenge, right, is the data sets that are needed. Every health plan has sort of outlined critical data to measure on, for any number of areas. But every EHR has a different way of formatting that data. They put it in a different corner of the room. And so it's not always very easy to just say, hey, give me labs, give me this pharmacy data, et cetera. And so those coding practices, when they're so varied and so different, it leads to a lot of incomplete data capture on the back end, right? More important, there's a lot of concern on the provider end, right? When we start to think about data sets and, oh, this health plan is asking for data tied to this contract, is how am I ensuring as a provider that I'm aligned to regulatory compliance? Am I sending the data that I am allowed to send? Am I honoring minimal necessary? Am I sending psychotherapy notes when I shouldn't be? Or, a plan insured patient who had a cash paid visit, is that data being sent over? And so it's, as you start to look at this, you say, gosh, this is a big challenge, right? So we got a lot of data everywhere, not a lot of people to do it. And when we come in to pull the data, it's going to be varied really sort of across the board, right? And this is what I hear from health plans that are trying to get this quality data, and they don't understand where what I got from the provider was, I see that the test was ordered, but I don't have a result, right? And so that becomes a big challenge where now we're chasing that information back and forth, right? So how do we start to sort of get ahead of that instead of, again, kind of chasing our tail? Go ahead, Garrett. I think poll question number 2 really hits on what challenges our audience has been dealing with.
All right, so this is pulling up poll question 2 on your screen here. And this is, what has been the biggest challenge for your organization related to value-based care? We have siloed data, EMR limitations, or resources. And again, these are anonymous, and we will show the results here shortly, but want to give you guys some time to vote. What has been the biggest challenge? I'm sure all of these are challenges, but if you had to pick the biggest challenge for your organization related to value-based care: siloed data, EMR limitations, or resources. And the results are still coming in, so we'll give everyone another minute or so to choose. right. I think most people have voted at this point, so I'm going to go ahead and close it down in another 5 long seconds. Five, four, three, two, and one. I'm laughing because there's like a little surge that always happens right when I threaten to close it down. So here we go. I'm going to go ahead and close it down and show the results. All right. So siloed data, we have 40% of you said that siloed data is the biggest challenge. 23% of you said EMR limitations, and 37% said resources.
About kind of evenly dispersed, I guess, across the board, right? As you kind of look at that, not surprised that resources and data silos are one and two for sure. I think a lot of the EHRs are starting to take advantage of more of the standards that are being published out there and what they can do around, HL7, fire, et cetera. But that makes a lot of sense. Um, so let's take that, right? Like a doomsday marshal over here telling you all the bad things that are happening in healthcare, how this is not going to be an easy initiative to take on, to sort of how do we improve data quality and validation in our value-based care contracts, right? So what I'm going to be sharing with you is really, this concept of that digital quality and validation is a need to have, not a nice to have. I think we've leaned too heavy into the world of interoperability and networks and frameworks in order for us to share data. But those are typically, driven off of the lowest common denominator of how data is shared. And it's not really getting into the collaboration and transparency that health plans, ACOs, providers need to have as it relates to improving the quality of care that we're providing and the transparency and collaboration that we have. And so as we kind of go through this, some of this will be more anchored towards an ACO or a provider, and then we'll talk a little bit about what's happening from the payer perspective as well. But one of the key things that we've really tried to encourage providers to do, right? You know that the payer is going to come back to you after you submit your HEDIS results for primary source verification. I need a PDF of the actual chart to show that you did what you said you did, or you're showing the same data elements. Where we've seen success is where you actually are working with a partner to drive that primary source verification on your own, right? Let's go and look at it before we send it to the payer. Let's ensure that like what was pulled and then we were going to send, let's go through there and start to understand, okay, what data is there, what discrepancies did we have, what's missing within the package, right, or the template that we were sending over. This is an unbelievable opportunity, right, for provider education, and to go back and say the reason we're not showing this result is because you're not coding it here or it's there, right? And so let's start to outline where are we missing that information. So doing that on the front end versus reactively when the payer comes back asking, you see what saying, okay, now I see that I'm missing all that information. I think that's really a key element, right? And then it's kind of setting up that, I'll say, transparency about what is it that we're going to share, right? Where it works well. Health plan says for my measurements and my submission to NCQA, these are the critical data elements that I want to be able to provide, right? Demographics, encounter data, immunization history, vital signs, and they're going to vary, right? Some of the state regulations are sort of changing on a annual basis, and so you want to be able to, obviously monitor that. But it's going to be important that we really have a clear understanding of health plan, what data are you expecting related to this versus what are you capable of pulling, right? This eliminates the, hey, I sent you that I ordered a test, but no resulted test, right? And so we start, sort of the gotchas and the trying to figure out where data is within that process. So we've really got to do a collaborative data validation process together, right? So how do we outline that, make sure that we're doing that crosswalk and standardization to match that up? I think obviously NCQA's pushed their data aggregation validation program. So the DAV program, which obviously allows for the elimination of the payer to go do primary source verification. If they're getting a stream of DAV certified data, that really enhances the payers, because now they're not spending their resources to go back and do that PSV, right, or the primary source verification. And then a lot of times those are clinicians who are having to do that work, right? And so they're really wanting to make sure that, hey, we've got that information in place. This also leads into, hey, as we've done it well, let's ensure that whatever's integrated or in that package, that we're not sending the insured self-paid patient psychotherapy notes. So you've got to make sure that there's some filters that are built into that. Long story short, digital quality and NCQA and HEDIS, like all of that's kind of wrapped up into HEDIS typically, but data quality applies to all use cases where payers and providers are collaborating, not just on HEDIS, right? It's for risk adjustment audits. It could be anything from a payment integrity audit, where we're ensuring that we're sending as a provider the appropriate additional documentation or data requested right back to the payer to appeal the denial or whatever that case may be. And so I want us to think globally around this. Although it's very focused in the world of quality today, it's going to expand on a daily basis. So it's certainly something that we've got to start to think about. So as you start to say, okay, we're going to take this digital quality and validation process forward, do the verification on your own. Let's ensure we've outlined the data elements, that we're not just trying to throw anything at it and hope that that's going to be enough data, right? That we're giving you the right amount of information that we're compliant with, and that we're really able to support multiple use cases. Poll
All right.
question number 3. I think
Time
it's
for
tied
question
to,
number
yeah, go for
three.
it.
Here we go. All right, I'm going to pull this one up on the screen for you like before. Okay. How much time per full-time employee or FTE does your organization spend during quality audits and primary source verification of clinical data? Up to 100 hours a year? Up to 1,000 hours a year? 5,000? 10,000? Where are you guys at? How much time per full-time employee does your organization spend doing quality audits, primary source verification of clinical data? And we will share these results soon, when it looks like many of you are still voting here. So I'll give some time. And the question is still, or the results are still coming in. So looks like most people at this point have voted. So I'm going to go ahead and close it down here in another 5 seconds. So I'm going to do 5, 4, 3, 2, and 1. And I'm going to go ahead and share these results. All right. So we're looking at, so 18% of you said up to 100 hours per year. We had 47% of you say 1,000 hours per year. 29% of you said up to 5,000. And then there was still 6% of you that said up to 10,000 hours per year.
Yeah, I mean, I think for my own knowledge, as I've been working in healthcare for the past 20 years, that it's sort of this hidden cost, right? That it's like it's a necessary evil, but it's certainly a lot of time, effort, energy. It leads to a lot of additional abrasion, and so between those payers and providers. So when you've seen the elimination of that in organizations that have partnered with DAV certified vendors, it certainly has shown a dramatic decrease of frustration on both sides of that fence. So I can relate to a lot of our audience around just the expense and the challenges around that. It certainly is not a fun pursuit. So I'm going to touch on this, kind of briefly, right? Like, how have validation and standardization process, how has that really driven healthcare quality? So maybe you kind of take a step back, right? Like, why value-based care? What's what's the big focus, right? And you can list anything that, ChatGPT or anybody else would tell you, right? It's accurate performance management, it's patient safety, quality, financial accountability to the agreements that you have in place, health plan to the ACO, ACO to the health plan or provider. Uh, I really want to say it's enhanced collaboration, right? When we start talking about data quality and improving that. And that's a big piece of this, right? Is that we've got to start thinking of this as it's more about establishing trust, right? Old enough with enough gray hair to hark back to the early 2000s when we were selling chins, or in Canada they call it a LIN, or we used to call it RIOs. Now it's known as health information exchanges, and it could be a hot sports opinion, but I believe that a lot of those HIEs that I saw early in 2008, 2009, they failed primarily because the Methodist hospital, the Baptist, the Catholic hospital, the independent hospital lacked one key thing in sharing data with each other, and that was trust, right? In these value-based care arrangements, we've put contracts in place and there's incentives in place to do that, but we still have to be open to trusting each other, right? And that trust can go point to point, or you work with a vendor that that you can kind of do that work. And I think from our own perspective, having done this for many years, like, what do most people get wrong? And I'll tell you, this is the honest truth is, if you're looking at this as a destination, right? Oh, well, we're going to achieve quality, data reporting. We're going to get to that point. You're going to set yourself up for failure. This is absolutely, when people think about this, this is a journey. It is not a destination. Collecting data alone, sending a pipe of information, setting up SFTPs, or we're going to leverage EHR provided solution does not solve world hunger. It does not solve this problem, right? It goes a lot deeper to a lot of those challenges we talked about, and so it's not something you can just set it and forget it, right? Why? Why do you say that, Brad? Well, metrics are changing with NCQA and state agencies on a pretty routine or annual basis, where new data elements are being included, or new screenings are being excluded, or immunizations that need to be accounted for. And so I think we stop short of where the real quality is to just, hey, let's just share information and let's kind of figure that out. The other side of that is, if you're only kind of setting it and forgetting it, what happens when, oh my gosh, you're not monitoring for the yield on immunizations or demographics, and the charts that we're getting are going down dramatically. Okay, so what happened there? Why are we not monitoring that and going back to see, well, do the providers, are they coding it somewhere different now? Are you putting it in a different place? And so you've really got to, look at it from a perspective of, hey, this is something we've got to, it's a lot of TLC, tender love and care, around the ability to kind of share this information. And see, that's what most people get wrong, is just a complete mindset around that. And I think some of that is because we focus so much on EHR solutions getting to a point where they were interoperable, or they had the ability to share data, that we've focused so much on, okay, I've set up an HL7, or I've sent CCDA, but that's not everything, right? Did we go through a standardization process? Did we look at the data elements that we've outlined together in sort of a collaborative approach, right? Like, did we have all of the critical elements you wanted, Mr. and Mrs. Health Plan? Okay, let's make sure that we've got that and we've validated that. So I think it's really a mindset around this, right? And so, for those who get it right, in a value-based care model, I think, I was working with my colleague who's present today, Misty Graham, sharing that, one provider organization saw, a 25% increase in BMI reporting, a 40% increase in childhood immunizations. And you start taking stats like that, and what does that do for the bottom line? How does that drive value in patient care, right, alone, right, in order to make sure that we're reaching patients that we haven't in the past? And so I want to stress that, this is very much in the world of, this is a journey. There's partnerships that you're going to align with from a health plan standpoint to ACOs, and ACOs to health plans, or third-party vendors. And these are things that are really important to start to think about because, not everybody wakes up every day thinking about quality care and, how best can we kind of share this information. So kind of got off my soapbox there, right? So what I'll say is we know that, the tsunami is not stopping. This is going to continue. We're going to be pushed for more and more of not only just data, but quality data. So what can we do as an organization, be it an ACO, be it a health plan, or a provider, in order to really start to drive from a crawl to a walk, or a walk to a run, or a run to a sprint around this world. And so, this is going to be a little bit of a broken record because it kind of falls in alignment with a lot of the things we've talked about, from the challenges and why we've built fences in healthcare that do need to be torn down at this point. But we have a lot of challenges around that. But I would challenge you to say, okay, how can we move forward? Number one, adopt standards where they exist, right? If there's a way to get data in a digital manner from a EHR, let's do that. Let's ensure that we're getting that information. But I would caution you to say, oh, I can get it from an HIE Brad, or I can use um, a Commonwealth, Health Alliance, et cetera. But they're stopping short of I'd say, the rigor or the depth of the data that really allows the health plan to use the information in a meaningful way for treatment operations, et cetera. And so I think it's important that we adopt new formats of that information, that we're able to seamlessly access that at scale. So it's really kind of looking at, okay, how do we start to adopt technology and integration where possible? I'm a big proponent. Let's eliminate all of the silos of data. It's hard enough for me to get a complete picture of my 81-year-old's mom's records when she's lived in College Station, Texas, and Oklahoma City. When all of that information's everywhere. Let alone for a health plan to be able to see information on Brad Hawkins from all of individual providers. And so, kind of centralizing that data aggregation, and also inclusive of not just the structured data, but that unstructured information like clinical notes, right? And let's get a real true complete, patient view. And that's going to be the critical component of that interoperability or integration is it giving me those critical data elements that I want? Those critical data elements and the shared goals and that trust that we talked about around data sharing, that's going to be one of the biggest elements that has to be in place at the forefront of any type of engagement in a value-based care world. Like, we've got to get in the boat together. If we're going to be in a collaborative approach, let's ensure that all parties are being set up for success. And what that looks like is, let's ensure that, I know how the game is scored, and I'm sharing the data that you need in order for you to be successful. Having that really set in place. I think sometimes what we've seen is a lot of the programs early on, right, in the value-based care world have been sort of billboard, right? Oh yeah, we're in value-based care. So what does that mean exactly, right? So nobody could really, articulate what that would look like. But I think it's important that you have very transparent conversations and understanding of, okay, what are we being measured on? What are they being measured on? What data are we requiring in order to measure that and really drive, better coordination of care. I'll pause there for a second because I think I want to stress something. This is the tip of the iceberg for what most of the health plans that are in today's audience are looking to do, right? If you're getting quality care back from the provider, you want to then in turn collaborate with that provider to say, thank you for that information. I've got insights on these members when they've been seen outside of your organization that I want to share back to you, right? So not just the one-way street of like, I'm just going to, send the train out, but also at some point, right? When do we start to think about how can we collaborate in that model where you have, diagnosis gaps or care gaps that you want to be able to share back to the provider that isn't currently within that EHR? Those contracts, those incentives, that collaboration is going to be critical as sort of the baseline or foundation for a lot of that work. Long story short, like, integrate with health IT systems. They're not going away. I think a lot of the EHRs are racing hard, right, to be more open to the concept of interoperability. But interoperability in itself, again, doesn't necessarily solve all of the challenges we're looking at. I've been a big proponent for, I'll say, like digital automation for 20 plus years, or how do we pull the data, without human intervention. I think sometimes, I've been remiss in almost leaning too much on man versus machine or machine versus man. The reality is as we adopt more in the interoperability space, all that allows us to do, right? And you hear this now with the comments and the arguments around AI a little bit, right? AI doesn't replace humans. Interoperability doesn't replace humans. It makes humans and the folks and the clinicians who are doing that crosswalk data standardization more efficient. It makes them more effective. It allows us to get that data more rapidly. So I think we've got to think differently of like, oh, I'm just going to automate this data. It's just going to flow. And it's like, no, let's have some checks and balances, right? Let's be nimble, because not every EHR is at a point from a readiness standpoint to do this. And we certainly have to have, individuals in place at every turn to make sure that we're, covering all of the bases, right? And we're seeing what's kind of falling behind, the couch or between the cracks or whatnot. All right, key takeaways, and I think I'm ending short, so I should get a round of applause at least for that, Garrett. If I'm 5 minutes early for a Southerner who talks too long. If I had you take away anything around today's conversation, right? Accurate data drives value-based success. Data does not. It's got to be accurate information, or we're really, it's all for naught, right? We need to have information that's reliable, and information that we can actually act on and we can use. You would never, as a provider, want to make a decision on a patient without the most accurate and real-time information about that patient, right? I'd rather make a decision, I don't want to make old decisions on old data or no data, right? But let's make sure that it's accurate. The operational efficiency is gained through automation, but it does not eliminate the need to checks and balances, look for where the data is falling behind the couch, as I said earlier, right? Let's look for that opportunity. So certainly we can gain improvements, but we still need people, and you still need a team or a partner who's looking at both sides of that equation to ensure that we're aligned. Probably the key element, right? Let's do that data validation and standardization. Let's not go ahead and start sending it and wait till it's wrong. Let's do a lot of that, quality assurance prior to, flipping the switch. Let's ensure that we're, enhancing the trust that's been built, that we're doing what you asked us to do and we're sending you that data. And I think that's going to be, one of the key elements really in all of this. And ultimately, this is really like I said, the foundation or the tip of the iceberg for where we're going in healthcare, where there was trust issues in the HIE space. When we put value-based care contracts in place, we start to promote for more, collaboration between payer and provider. And we're having to do that more and more because we've got an aging population that has more and more chronic conditions. And so we need to be thinking about how are we treating with a lot more urgency to ensure that we're hitting all the care gaps, so we're looking at all the diagnosis areas that maybe we're missing. Having that in a repository, ensuring that drives that seamless care coordination is going to be really important. And so hopefully this was valuable information. Certainly we are here to answer any questions, and I'll turn it back over to you, Garrett.
Okay, so yes, and thank you, Brad. This is great, and obviously there's a lot here. So if you do have a question for Brad, go ahead and ask that now using your control module, and we're going to get to as many of them as we can. We do have a few already, so I'm going to go ahead and ask this one first in no particular order. How do you work with integration challenges of smaller providers who may not have data systems in place?
Yeah, I mean, it's a good question, right? I mean, I think depending on the readiness of the organization, there's a lot of different, I'll say, quote unquote, options, right? From an integration standpoint, there's EHRs that, you can go directly to the EHR, i.e. an Athena, right? And that allows for, an opt-in for that they, do it more of an opt-in for their membership, whereas you have others who more on the long tail. And so, I mean, I'll speak for MRO's perspective. What we've seen, is, the ability to develop our own integration methodology to pull the appropriate data from that EHR and work with that provider in order to understand where's that data mapped, and how can we run queries into that EHR in order to pull that information. In other cases, it's working with those providers who are commonly and known as in the marketplace on the long tail of EHRs. It's not the Epics and Cerners and Meditechs of the world. And so in those cases, you work closely and collaboratively with those folks to say, how do we build you know a supplemental data file that can be pushed on a monthly basis on members who've had encounters. And so variety of ways really to kind of dive in and look at it. Ultimately it's the consultant answer, Garrett, is it depends really on what's available within that EHR, what APIs, quote unquote, they may or may not have.
Yeah, that makes sense. Okay, next question is how does MRO help payers prepare for the increasing complexity of value-based care models?
Yeah, I mean, I think from MRO's perspective, what we've really driven through our work with health plans as well as with the ACOs, right, is really facilitating, I would say a great deal of some of the content that we've shared today, right? Let's all understand that data alone is not the key, right? It's let's do the quality of data. And so an entire group of clinicians that are working very collaboratively with the health plan and the ACO to say, okay, let's outline those critical data elements that are required for health plan to report on. It's going to be different within each member or provider org within that ACO, because there could be a handful of different EHRs in that model. So we've sort of outlined, okay, what is it that we're trying to achieve here, right? Let's outline those data elements. Let's ensure that we've got a methodology within the entire ACO that we're able to pull that data or get a file pushed to us that allows us to accelerate that, so that it's a timely submission of data. Back to the health plan. And then last but not least, we are DAV certified and have been doing that for a couple of years now. And so that's driven a lot of value in sort of value-based care model for health plans and for the ACOs, because now there's not that, ongoing abrasion and additional lift when, the health plan's got to come into the provider side and say, yeah, I know you sent me the data through MRO, but let me go back and get a PDF copy of that to make sure I know what data was done. I'll ask Misty to comment. I know she's the expert in the world of ACOs as well, if she had anything additional to share. Now
Yes,
that I've put her on the spot.
we have a secret guest that's been in the background, and that is Misty, who is also with MRO. And
Yeah.
so, Misty, feel free to weigh in if you would like. But
Yeah, thanks, Garrett. Hello, everybody. I think Brad did a really great job. I don't have anything additional to add.
okay,
I paid her before this to say that. So
there you go. There you go. All right. Next question here is, are you able to provide examples of how MRO solution has successfully addressed data challenges for other payers, particularly in terms of cost savings or improved outcomes?
yeah, I'd really be happy to. I think probably the best highlight is to kind of share a case study with you related to the work that we've done with Care First. We're connected to nearly 2 million lives within the DMV, or the DC, Delaware, Maryland, Virginia market, within Care First memberships, where we're sharing data on a monthly basis across over 200, I think, 40 practices today, across all different EHRs. They've seen a 0.5 increase in their HEDIS scores since we've been live, and so that's certainly driven significant value. It's driven significant cost savings in the elimination of the PSV work that they've had to do, given that, we're certified for multiple cohort and cluster environment. That would be, one of the key elements working with them now, really to accelerate the acquisition of risk adjustment charts and HCC coding, right? And so there's certainly quite a bit of incentive on the back end of that, where the more data they're able to look at and be aware of in a rapid pace has driven just a great collaboration across the board. I think the providers and the ACOs we work with in that area of the country have highlighted, I didn't have the people, right, resources to do this work. I don't have the time to go do this work. Uh, and so, working with MRO has been a a benefit to, I will say, both sides of the aisle, since we're in the political season.
Yeah, no doubt. Definitely coming up on that. Next question here is, how does your platform handle unstructured data?
Yeah, so ultimately we're able to get, based off the integration, we're able to pull in, really all of the clinical notes, which allow us to pull in the relevant data from that's unstructured, right, to be able to place that alongside, the traditional, say, labs, meds, etc. That's been extremely helpful, as we've worked with Care First specifically, right, around, pulling in some of the social determinants of health data and a lot of the demographic data. And so it's really been more of a factor of just not stopping at the least common denominator of
Yeah.
information. Misty, I'm going to call on you again because I know you've got so much expertise. I'll let you weigh in as well from a product standpoint.
Sure, absolutely. So, yeah, one of the things that we use is natural language processing, and that natural language processing, if you think about kind of like AI tools, right, that people are using, allows us to pull different data from clinical notes to make sure that it's usable for value-based care. Additionally, we do crosswalking of codes as well, and that allows us to make sure that if something's maybe coded similarly, it falls into the right bucket. So by doing that, and taking that unstructured data, you now have visibility to a longitudinal patient record, which again just leads to better value-based care outcomes.
And I think, thank you for commenting, Misty, because I think that's an important part, Garrett, that we talked about, right? I would love to show up and say, hey, I've got the technology solution that's going to solve world hunger, but it's the clinical team that understands what it's like to be on the front lines with the provider side. They also understand what the payer's looking for with that unstructured data, and doing that crosswalk, regardless if it's a DAV certified stream or not, but doing that crosswalk to ensure that quality is at the kind of the forefront of everything we're doing in that data sharing, that we're kind of honoring the patient's wishes around confidentiality and minimal necessary, but also sharing relevant information that's needed by the health plan in order to drive that quality.
Wonderful. Next question here is, what have you learned about how to build the trust you mentioned with regard to validating and standardizing data?
Yeah, I mean, I think that goes to it, right? I think it's having a clear, conversation of, hey, this is the work we're looking to do. We're not looking to turn on a fire hose of information. I'm not giving I'm not giving the health plan unfettered access to that EHR or to the provider. It's really kind of serving the provider or the patient to ensure that we're sending the right information. So that trust is built on setting clear expectations around that collaboration, sitting down and ensuring that we've not tried to ready, fire, aim on a lot of this, right? It's sitting down, having a clear understanding of what are we looking to accomplish, setting out the data elements needed, and then being transparent at every turn, right? One provider, you should know where your data is going. Payer, you should know, what data elements are missing, and then monitoring our own efforts, right? As I kind of talked about, this is not a destination, it's a journey. And our clinical team is looking around that yield on a month to month basis or on a day to day basis, right? Around why are we not seeing this specific data element? Why does it continue to decline month to month, or why does it go from 98% to 0%, right? Something happened within that practice. They're starting to code information, or kind of place it somewhere differently, right? And so it's really rolling up your sleeves and working collaboratively, right? Having a 15-year-old who's going to his first homecoming, dance, as I've tried to tell him, trust is it's earned, it's not given. And so I think in a lot of ways we're doing the same thing, right? Is earning the trust through the hard work that the team's put forth. And so far, feel proud of the results and the collaborations that we've had with the health plans we're working with.
Very good, very good. Well, it looks like that is actually all the questions that came in for right now. If you do have a question for our speaker, you can go ahead and enter that now, and like I said, someone will reach out to you via email to make sure that we answer that question. But as we close out, first of all, Brad, thank you so much for a very meaningful presentation. I think this was obviously one that you'll probably want to watch again. So, and we're going to be sending you a recording to where you'll be able to have a link to the presentation as well as to where you can download the slides. So feel free to do that. But as we close out, I wanted to encourage you to head over to vbcexhibithall.com, and you can check out the MRO virtual exhibit booth. And here's where you can access resources and read up on them and what they're doing, and kind of educate yourself more on that, and of course reach out to them. But if you would like to reach out to the MRO team, feel free to do so. If you want to go to that last slide, Brad, their contact information is here on the screen, or at least Brad's is, and you can reach out to him directly, or feel free to reach out to me. I'm happy to facilitate an introduction if that would be more helpful. But thank you all again so much for joining us today. And for those of you who are in the wrath of the hurricane that just swept through, our thoughts are with you. Hopefully that'll be a quick recovery. But hope you all enjoy it, this presentation, and will join us for the next one. Have a great rest of your day.
Thanks, Garrett. Thank you all.